Myself, Dr. Raktin Mukherjee, Assistant Professor and Head of the Department, Shri P.M. Patel Institute of PG Studies and Research in Science, affiliated to Sardar Patel University, Anand. Today, I will be talking about the drugs used in the treatment of epilepsy. So, we come to the treatment of epilepsy. Whenever you talk about treatment of epilepsy, always we have to treat epilepsy with AEDs, that is anti-epileptic drugs. Anti-epileptic drugs generally attempt to correct the disruption of normal electrical functionality. How it tries to correct? It tries to correct by decrease in excitatory process. Any excitatory processes or neurotransmission which is decreased, it tries to correct it to the normal level. Likewise, if there is any process which is inhibited, it tries to increase that process. So, treatment with anti-epileptic drugs follows two treatment paradigm: modulation of excitatory or inhibitory process depending on the upregulation or downregulation or changes in the neurotransmitters. Now, the question is how the anti-epileptic drugs, how it control seizures. Of course, epileptic seizures are controlled by nervous system neurotransmitters, and automatically some of the neurotransmitters, primary excitatory neurotransmitter is glutamate, primary inhibitory neurotransmitter is GABA, and there is a role of ion channel. These ion channels control the conduction of electrical impulses in neurons. 30% of the patients do not respond to the downstream electrical impulses in the neurons. So, they have to be treated with alternative medical treatment. So, how the control of neuronal excitability is done? You control neuronal excitability by blocking the ion channels. Which ion channels? You block ion channels such as sodium, potassium and calcium. Using appropriate pharmacological agents, you block these neuronal channels and automatically the excitability is controlled. What are the mechanism of commonly used AEDs, anti-epileptic drugs? Some of the commonly used anti-epileptic drugs are phenytoin, carbamazepine, valproic acid. These are the commonly used drugs: phenytoin, carbamazepine and valproic acid. Since I mentioned ion channels are very important in control of neuronal excitability or how epilepsy is controlled by the drugs, we have a fantastic research paper, which the title of the paper is Ion Channels and Epilepsy from Current Pharmaceutical Design. This research paper explains the role of ion channels in epilepsy, and some of the things we have already taken in our earlier slide. Now, what are the newer anti-epileptic drugs? These are the old drugs that I mentioned. What are the latest anti-epileptic drugs? The latest anti-epileptic drugs, they act by interfering with the synthesis, the function, the release and metabolism of neurotransmitters and their receptors. What are the newer anti-epileptic drugs? You have felbamate 1993, gabapentin 1993, lamotrigine 1994. I just mentioned the year of discovery as well. Topiramate 1996, Tiagabine 1998, very important drug. Then Levetiracetam 1999, another important drug. I have included both these drugs in my lecture. Oxcarbazepine 2000 and zonisamide also in 2000, then pregabalin 2005. As I mentioned, you just have to remember the name of the drug. So, more than understanding, your memory or remembrance is something which you have to understand in the third video of epilepsy. And I have given a snapshot summary from a research paper from Epilepsy in Behavior, just for your information. You have lacosamide, escitalopram, and latest retigabine in 2011. These are the latest anti-epileptic drugs. And of course, for writing in a Sardar Patel University, this can be a very good diagram. Okay. Excitatory neuron and postsynaptic neuron, inhibitory neuron. So, which are the drugs which acts at sodium channel blockade? Which are the drugs which act at potassium channel activation, antagonism of glutamate, potentiation of GABA activity, calcium channel blockade, alpha to delta modulation, modulation of S2VA mediated neurotransmitter release. So, this one single slide is equivalent to 10 pages of research paper, because in one single slide, what are the different drugs and what is the role, which ion channel or which neurotransmitter do they target, that is very nicely mentioned. Potentiation of GABA activity takes place by barbiturates, felbamate, stridipentol, tiagabine, topiramate, valproate, and Vigabatrin. Potassium channel activation lone drug is retigabine. Antagonism of glutamate, you have felbamate, limetrobine, and topiramate. Alpha to delta modulation is gabapentin and pregabalin. Calcium channel blocker is ethosuximide, lamotrigine, and zonisamide. A small bit of remembrance or memory you have to do today itself. So, this is your list of drugs, and you can, I have taken this from the new anti-epileptic drugs, the neuropharmacological and clinical indications. This paper you can refer for more details. Of course, otherwise whatever I have given is more than sufficient from Sardar Patel University. Now, I will take each drug separately, some of the important ones. Levetiracetam, I have already given the molecular structure, not needed for examination, just for your information, and the pictorial representation how the injection vial looks. This was first approved in US in the year 1999. This was for patients with partial onset of seizure. You have pyrrolidine derivative that differs from all other currently approved AED on its chemical structure and pharmacological profile, and a mechanism of action as a consequence possesses unique pharmacological properties. So, I hope this was the role of levetiracetam. We continue with levetiracetam, anti-epileptic drug. This drug, it binds to the synaptic vesicle glycoprotein SV2A. After binding to the synaptic vesicle glycoprotein SV2A, it inhibits the presynaptic calcium channels, and this presynaptic mechanisms are thought to impede the impulse conduction across the synapses. And the mechanism of this drug is already mentioned in the review article from Neurologia Medica Chirurgica. This is from Wolfgang Loscher. The article states that synaptic vesicle glycoprotein 2A ligands in the treatment of epilepsy and beyond. So, it binds to the glycoprotein. Someone asks you, what is the target of levetiracetam the target is the S2VA, that is synaptic vesicle glycoprotein, and which ion is affected? It inhibits presynaptic calcium channels, presynaptic calcium channels. There you have the modulation of S2VA mediated neurotransmitter release, that is Levetiracetam. There it is, you have the synaptic vesicle protein S2VA, and this drug will bind to the synaptic vesicle glycoprotein S2VA and inhibits. Once it inhibits the presynaptic calcium channels, the presynaptic mechanisms are thought to impede the conduction across the synapses. The next drug that we are going to study is Vigabatrin. Vigabatrin is the first designer drug in the epilepsy field. It's the first designer drug, and this drug is a vinyl substituted analog of neurotransmitter GABA. This drug acts by inhibiting the GABA transaminase. This drug is effective in patients who are unresponsive to conventional drugs, but however, this drug comes with a price. That are some of the main side effects. Some of the major side effects are drowsiness, behavioral and mood changes, and the drug also has certain interactions, such as the drug decreases, this drug interacts with another drug and it decreases the phenytoin concentration. To see further, Vigabatrin inhibition of GABA reuptake by depressing GABA transporter GAT1. This removes synaptically released GABA into the neurons and glial cell, and thus potentiates GABA mediated neuronal inhibition. Vigabatrin also blocks GABA transaminase, which is the major GABA degrading enzyme. So, major mechanism is inhibition of GABA reuptake. How it inhibits? By depressing the GABA transporter GAT1, and also it blocks GABA transaminase, the major GABA degrading enzyme. If you refer to this research paper by Peruca and Mula from 2013, Epilepsy and Behavior, you will see that Vigabatrin, as we saw, it will decrease the GABA neurotransmitter, and just now we saw the decrease is mediated by either inhibition of GABA reuptake by depressing GABA transporter GAT1, or it can also lead to the blocking of GABA transaminase. This GABA transaminase is the major GABA degrading enzyme. Next drug in our list is Tiagabine. Tiagabine blocks reuptake of GABA via GABA transporter 1, also called as GAT1, GABA transporter 1. Inhibition of GABA reuptake by depressing GABA transporter 1 removes synaptically released GABA into the neuronal glial cells, and thus potentiates GABA mediated neuronal inhibition. Thus, Tiagabine increases the level of extracellular GABA in the brain. This is Tiagabine. As we know, Tiagabine inhibits GABA1 receptors GAT1, and it also inhibits glial GAT1 receptor, and thus by inhibiting the GAT1 receptor, the Tiagabine inhibits the GABA reuptake by depressing the GABA transporter GAT1. This in turn removes synaptically released GABA into the neurons and the glial cells, and thus potentiates GABA mediated neuronal. The more GABA will be there means more GABA it will lead to the potentiation of GABA mediated neuronal inhibition, and thus it increases the level of extracellular GABA in the brain. There is an increase in extracellular GABA in the brain. One more diagram to illustrate the role of Tiagabine. This is Tiagabine, and Tiagabine acts by potentiation of GABA activity. Potentiation, it means increases the GABA activity. In the postsynaptic neurons, you have more GABA reuptake by the neurotransmitters, and that leads to the control of epileptic seizures. Apart from that, Tiagabine is a valuable drug for adjuncting treatment of refractory partial epilepsy with or without secondary generalization. This drug is used in unclassified epilepsy as well as in generalized epilepsy to be avoided. Main advantage of this drug is the mechanism of action. This is very distinct from other anti-epileptic drugs and is clearly demonstrated in efficacy in partial seizures. This drug is very effective. The main disadvantage of this drug is short half-life, and this shorter half-life necessitates multiple daily dosing. So, one has to take more number of medicine pills per day, and there is also a need to slow the dose titration. There are CNS adverse effects, and there is a efficacy spectrum which is related to the partial seizure. These are some of the pharmacological disadvantages, and in such cases you need to have a dose modification which is not needed in renal diseases. So, it is a renal safe or kidney safe drug, but of course, for hepatic diseases you have to modify the dose, and a drug which has to be taken more number of times, and that too it is hepatotoxic, caution has always warranted to cause long term hepatotoxicity if excess dose is taken or dose is not reduced. Now, we will anti-epileptic drugs and GABA. Anti-epileptic drugs can enhance the effect of GABA, that is benzodiazepam. What is the mechanism of action? You have barbiturates or benzodiazepines. They will bind to GABA A receptor at different allosteric site. By binding to GABA A receptor, it will facilitate GABA action. Barbiturates increase the duration, and benzodiazepines increase frequency of opening of calcium channel. Once calcium channel opens, the membrane becomes hyperpolarized, that is more negative. It becomes hyperpolarized, and hyperpolarized mechanism of action leads to CNS depression. So, therefore, at higher doses, barbiturates can act as GABA mimetic. It can also act as a GABA mimetic at higher doses, but otherwise anti-epileptic drugs can enhance the effect of GABA, that is benzodiazepine. Now, one of the reasons why conventional pharmacological strategies fail, conventional pharmacological strategies fail due to the development of pharmacoresistance. There is a global manipulation of ion channels at higher and more effective doses, so it leads to pharmacoresistance, and this leads to widespread side effects, particularly in cognitive domain. Now, what are the alternative treatments for epilepsy? One is surgical resection of focal focus of seizure, that is the origin from where the seizure takes place, that is surgical option. Apart from that, you have surgical removal of the seizure origin. You can disrupt or limit the spread of seizure throughout the brain. What are the caution that has to be taken during brain surgery for epilepsy? You have to ensure that the epileptogenic focus does not reside in cortical areas responsible for speech. If you are resecting those areas, your epilepsy may be cured, but you will suffer from speech disorders. Surgical excision without compromising, you have to do exercise lots of caution. You should not touch those areas of the brain which are overlapping with epileptic seizure along with vital functions. Otherwise, the surgery may be successful, but you will be bedridden because of alternate neurological problems. The surgery has been successful in reducing seizures, and in some instances they may completely alleviate the need for other treatment. So, surgical options are always good when medicines are not having that prolonged effect. Now, what are the types of brain surgery for epilepsy? You have resective surgery, where the entire mass is resected out, multiple subpile transection, multiple areas where the seizure takes place, they are dissected out. Hemispherectomy, that is entire hemisphere where the origin takes place is surgically removed, and corpus callosotomy, where corpus callosum is removed or surgically excised. Now, what are the alternative treatments for epilepsy? Some of the alternative treatments, and this can be again lots of biochemistry, it can be asked in exam. Alternative treatments for epilepsy, dietary therapies are there. What the dietary therapies do? They may provide seizure control in drug resistant forms of epilepsy. You take medicine, but the drugs are resistant, surgery is not possible, diet therapy can also help. Therapeutic effect of fasting on control of seizure has been known since the time of Hippocrates. In epileptic patients, fasting has very good prognostic significance. Now, the question is how fasting suppresses seizure. You are not taking meal, how it is going to affect the seizure? Fasting suppresses the seizure can be mimicked by high fat, low carbohydrate, high fat, low carbohydrate, ketogenic diet. Ketogenic diet is the basis for dietary modification of anti-epileptic treatment. So, what is this diet therapy? This is promising for identifying new anti-seizure targets. They provide insight into the pathophysiology of the epileptic brain. So, how ketogenic diet helps? There is a reduced carbohydrate intake which decreases the glucose utilization as energy source. Instead, the liver utilizes fatty acids to produce ketone bodies, mainly the beta hydroxybutyrate and acetoacetate. Once you are taking less carbs, your carbohydrate consumption decreases. Less carbohydrate means glucose utilization as energy source is there. Instead of, the liver utilizes fatty acids and ketone bodies, mainly beta hydroxybutyrate and acetoacetate. So, how ketogenic diet helps? The neurons in turn will use ketone bodies for cellular metabolism in place of glucose. So, ketone bodies in place of glucose. What is the mechanism of action of ketogenic diet? You have free fatty acids undergoing beta oxidation to acetyl CoA. Acetyl CoA produces ketone bodies. Ketone bodies will travel through bloodstream from liver and it goes to the brain. The brain, you have ketone bodies will be converted to acetyl coenzyme A. It will enter the TCA cycle. It will increase ATP and it will also increase adenosine. Ketone bodies will have prolonged effect on GABA. It increases GABA. It decreases glutamate. It modulates ion channel, and together the ketone bodies will decrease neuronal excitability. By decreasing neuronal excitability, it will favor treatment for epileptic patients. You also have increase intracellular ATP. Increase intracellular ATP along with its concentration gradient into the panaxin to the extracellular space. Here it is degraded by nucleosidases to its core constituent adenosine, and adenosine can act on inhibitory A1 receptor. Already we have seen the adenosine A1 receptor to cause presynaptic inhibition, and in epilepsy lots of activation takes place. We literally want presynaptic inhibition. Once the presynaptic inhibition takes place and associated with hyperpolarization, this will prevent seizures and protect us against epileptic seizures. That is the role of diets. Now, what are the hypotheses to explain anticonvulsant action of ketogenic diet? Ketone bodies themselves may not necessarily be the primary factor. The underlying mechanisms leading to reduced seizure activity are largely unknown, but we have explained some of the aspects. Some of the beneficial changes induced by ketogenic diet therapy, few beneficial metabolic changes. One is increased level of adenosine, decreased GABA, decreased glutamate, and thus direct action of ketone bodies on ion channel reduces neuronal excitability. And one of the major paradigm of epileptic treatment is to reduce neuronal excitability either with drugs or by diet or by surgical removal of the epileptogenic areas. What are the beneficial metabolic changes induced by ketogenic diet therapy? Ketosis increases mitochondrial biogenesis. This leads to production of ATP. ATP in turn is a direct metabolic precursor of adenosine. ATP leaves the neuron via transmembrane channel panaxin and thus is converted to adenosine extracellularly. It is this unique metabolic modulation which paves way for further research with the ketogenic diet. So, let us see the diagram once again, revisit the diagram into the role of ATP, the ketogenic diet. As you see, ketosis increases mitochondrial biogenesis. This leads to production of ATP. You can see there is an increase in ATP. This increased ATP leaves the neuron through panaxin, a transmembrane channel. After leaving the neuron, ATP gets converted to adenosine under the influence of nucleotidases, and this adenosine is a unique metabolic modulation which paves way for further research into ketogenic diet. So, adenosine, it will bind to the adenosine A1R receptor. After binding to A1R receptor, it causes presynaptic inhibition. Presynaptic inhibition and hyperpolarization to prevent seizure. The cyclic AMP, cyclic adenosine monophosphate increases. There are certain current treatment paradigms that also we will see. Some of the current treatment paradigms harness endogenous anticonvulsant mechanisms of the brain therapeutically. Some of these are by focal cooling into the area which generates seizure, cell therapy, gene therapy, and focal adenosine augmentation. This is a very promising area. You locally increase the adenosine concentration in the areas or epileptogenic areas which are responsible for seizures. Finally, thank you for listening to my video on